Okay, hello, my name is Elizabeth Douglas, and I'm a member of Student Leadership Johns Creek. The person I have the pleasure to introduce is Dr. Rasmussen, who is a professor in the departments of pediatrics and epidemiology at the University of Florida. Before this, she served for 20 years at the CDC in Atlanta, where she served in the National Center on Birth Defects and Developmental Disabilities, as well as the Deputy Director of the Influenza Coordination Unit, and as the Acting Director of the Office of Public Health Preparedness and Response. She was also the editor-in-chief of the CDC's Morbidity and Mortality newspaper, as well as a lead author of the paper confirming Zika virus as a cause of birth defects. It's a pleasure to have you here, and I'm so excited to see what you have to say.
Great, thanks so much. I see a lot of, not faces, I see a lot of just people's names. Do you have people turn off their cameras, Irene?
I typically do, just because I want them to pay attention to you and I don't want their bandwidth to take up your bandwidth.
Okay.
But whenever you guys want to unmute and ask a question, also try and unmute your video as well. And I am friends with Dr. Rasmussen. Her and I have spent many a time in a spin room together. So, anyway, it's a pleasure to have you. So I'm going to mute myself.
Great. Well, what I thought I would talk about today is kind of an overview of my career. So it's, you know, I think that gives you sort of the breadth of the kinds of things that you can do in medicine. And I feel like I've had a great opportunity to do a lot of cool things in my 20 years at CDC and then in my time at University of Florida. So my title is From Down Syndrome to Congenital Zika Syndrome, but you'll see now I've done a lot of work on COVID in the recent times. So a review of my career so far. And the last time I gave this talk was a year ago, and so I had to add the stuff about, I gave it at Children's Hospital of Philadelphia at CHOP, and so I've added the stuff about COVID, and so we can talk a little bit about that at the end. Hopefully that'll be of interest. So I'm going to start with sort of a personal side, if I can get this to work. There's my family. Actually, I have another sister, but she was not in this picture. She was born after this. My mom, my dad, my brother, my sister, and me. And some of this kind of helps give the background of how I got started in this interest in medicine and especially in genetics. As you can see in the picture, my little brother had Down syndrome. He died this last year, but he had Down syndrome, and he it was in a time when people with Down syndrome were not encouraged to stay with their families. My parents were encouraged to put him in an institution, but my parents decided to keep him at home. He was just a little bit younger than me. He was born about a year and a half after me. The other thing that you can't see in this picture is that my dad at this time, about the year after I was born, he had a paralytic event, and he was paralyzed from the waist down. They think he had polio. Not entirely sure what happened, but he had a severe disability, and it made me very interested in infectious diseases as potential causes of severe illness. So when I came to CDC, I went to medical school at the University of Florida. Then I went to my residency in pediatrics at Harvard at Mass General Hospital. And then I went to Johns Hopkins for my genetics. And then I came back to University of Florida for a couple of years as a junior faculty member and was offered a job at CDC and went to CDC. And I was actually hired at CDC to work on a large study of birth defects. And I was the expert on the clinical side of things, and I was the expert on the biologics, on the DNA, of collecting DNA from all these babies and their parents for in 10 different centers in the United States. Well, while I was there, I got interested. There was some time each week that we got to do research that we were really interested in ourselves. And because of my brother, and this is another picture of my brother, I was really interested in how long did people with Down syndrome live. And so I decided I wanted to do a study on that. And what we decided to use is to use the death certificates. And every time somebody dies in the United States, a death certificate is filled out. It's filled out in every hospital in the United States, or if the person dies outside a hospital, it's filled out by a medical examiner. And those data are available actually to any researcher, not just to people at CDC. And so we use the multiple cause mortality files, and this was a study that was done a long time ago, you'll see, because it was 1983 to 1997. We selected all cases that had the code for Down syndrome, and there were almost 20,000 cases, or 18,000 cases. And we looked at what was the average age at death that was listed in the death certificate to approximate survival. And I'm going to tell you about this because I think we found some really interesting things, and things that I think a story that I hope that actually I'm recently working with someone that I'm hoping we can kind of follow up on some of these questions that were raised in this study. So we also looked at the standardized mortality odds ratio, which is a way of looking at someone who has Down syndrome that dies. Are they more likely to have this listed on their death certificate than the SMOR is greater than 1? Or is it less likely to be listed on the death certificate and then it's less than 1? So it's adjusted for age, race, sex, and year of death. So it's not like just because someone with Down syndrome usually doesn't survive as long as the general population, that isn't the reason that they might not be getting cancer, because it's adjusting. There's a statistical adjustment for their age. So first of all, this is the first thing that we looked at, and this was published in a journal called The Lancet that's published in the United Kingdom. And we saw that over the years, the survival of people with Down syndrome was really improving. And some of this was when I first was starting to get interested in medicine, people with Down syndrome, kids with Down syndrome, families weren't even offered the opportunity to have surgery if they had heart defects. People had such a low thought of people with Down syndrome that they didn't even offer them surgery. So this is somewhat because they weren't being put in institutions anymore. You remember me saying that my brother, if my parents had allowed it, would have been put in an institution. And also because were getting better medical care. So you can see from 1983 to 1997, the average survival had gone from 25 years to about 49 years here. But then we started seeing some other things that were really concerning. And this sort of brings us back to the COVID thing, because some of this COVID-19, we're seeing some of these racial disparities. But here you can see the huge racial disparity that we saw. And at first I thought, this is impossible. There cannot be in the United States this much racial disparity. Whites were living to age 50 with Down syndrome. Blacks were living to age 25, and then others were living to about 10 years of age. And we checked our analyses this way and that, and really couldn't find any other reason other than race. So then this is the SMOR. So this is looking at our people, what's likely to cause people with Down syndrome to die. And what we saw is much more often than a person without Down syndrome, a person with Down syndrome had congenital heart disease. That's what the CHD stands for. And we all know that kids with Down syndrome have about a 50% chance of having a heart defect. Same thing with dementia. This is what Alzheimer's is much more common among persons with Down syndrome. And this is what my brother developed and why he died this last year at age 60. So dementia was much more often listed. Hypothyroidism. So you can see that death certificates, nobody dies of, or very unlikely are you to die of a low thyroid condition, but it is very common in Down syndrome, and death certificates list other things that you have at the time of death. Other things were pneumonia. It's interesting, just recently, CDC has recognized Down syndrome to be something that puts you at increased risk for COVID-19. And so people with Down syndrome are have been jumped to the list of people that should get the vaccine sooner. Viral hepatitis, that's probably because people were living in institutions where they were exposed to other people's blood and body fluids. Leukemia, we knew leukemia was more common among people with Down syndrome. But then we saw this other thing, that other malignancy was really much, much less. So why are people with Down syndrome less likely? And what we found is this was solid tumors. It was things like colon cancer or breast cancer, other cancers that most people when they get older get. And I told you that it's adjusted for age. So it's not just that they're not living long enough. So we had known for a lot of years that men with Down syndrome were at increased risk of testicular cancer. That's because they can have undescended testes, and that puts you at increased risk of cancer if someone doesn't do surgery to bring your testes down. Leukemia. Then you see these are all the pancreatic cancer, uterine, liver, and I'll show you the next page, prostate, colon, ovarian, breast, malignant melanoma, lung, all these things that you know, at my age, I worry about developing. People with Down syndrome are much, much, much less likely to get that kind of cancer. And we were able to find another study that had shown something similar. It was a much smaller study than ours. It had been done in Denmark, and now I'm actually working on several projects with Dr. Hasle in Denmark. And our conclusion was that survival is improving, but there's really a significant racial disparity. And the risk for solid tumors is substantially decreased. But as you always say in science, more study is needed. So then we started working, we published this in the journal Lancet in the United Kingdom. And then we tried to do more studies to try to look at what we could find. So we looked at survival again in a metro Atlanta. I don't have time to give you all the details, but what we found is that being African-American, being Black in Atlanta, and having, if you're a baby with Down syndrome, your chance of dying was much higher than in a baby that was white. And that it was about the same as having a congenital heart defect. So being Black was enough of a risk factor similar to the risk factor of having a congenital heart defect, which was really very concerning to us. Here's some other papers we published over the next few years. Here you can see we started working with the Denmark group. We looked at survival there. Of course, we couldn't look at racial disparity because there isn't a lot of racial disparity. There isn't a lot of different races in Denmark. We looked at hospitalizations. We looked at social conditions. How likely were people to work? Were they likely to get married? Did they have children? And then we looked at the same question, low risk of solid tumors in persons with Down syndrome in a large data set in Denmark, and showed the same thing that we saw in our study in the United States. Of interest after this, a professor that heard me speak when I was giving a talk, I had gone to visit my friends at Hopkins, and he heard me give a talk, and he came up afterwards and said, we're working on this and I'd like to tell you about it. Now we've become friends. And what they found is there is a gene on chromosome 21, and that if you have 3 copies, which, you know, that Down syndrome is 3 copies of chromosome 21. If you have 3 copies of that gene, you're much less likely to develop solid tumors. And that could help us to understand ways to prevent cancer in people without Down syndrome. So it's really ended up being an interesting story. So then I'm going to tell you about, so I had worked on that. I'd worked on this large birth effect study. Then I started getting interested in infections, and I didn't really know anything about infections. I had an interest because I've told you about my dad that we think had polio. And so I was not involved in this study, but in December of 2002, this was reported in the MNWR, which you hear later on, I became the editor-in-chief of. And there was a baby born with, the mom had had West Nile virus infection. The baby had severe birth defects, brain defects, eye defects, similar to what you see in other kinds of infectious causes of birth defects, like rubella. You all know that rubella causes birth defects. You all know that cytomegalovirus is another cause of birth defects, and it causes brain problems, eye problems. And so it was consistent with what we saw. So I started getting interested in infections and started working with a number of other people. Of course, CDC has a lot of experts in infections, and I started working with some of them. And you can see here just a handful of the papers that we published in those first few years. Then I started getting interested, as I was reading all these papers, I started getting interested of whether there was going to be a pandemic in the future. And at that time, the Bush administration, Bush II, had been concerned about a pandemic. He'd read a book about pandemics and had invested a lot of money in preparing for a future pandemic. And while the rest of CDC was focusing on how to prepare for this pandemic, I was focused on what are we going to do about pregnant women, because pregnant women were the group that I really cared about. So we started working on this paper, and these are two of my colleagues, Joe Brzee, who was an expert on influenza, and then my good friend and colleague, now we've written like 62 papers together, Denise Jamieson. She's now chair of OBGYN at Emory. And we wrote this paper on influenza and pregnancy. And what we wrote is, if there's an influenza pandemic, we're really worried about pregnant women. We're worried about pregnant women because we know they get sicker with flu. They're more likely to have severe illness and even die. And we know that sometimes they're hesitant to take medications. And we knew that there was this medication, you all have heard of Tamiflu, the oseltamivir, Tamiflu that you can give, but we were worried that pregnant women might be worried about taking it because not wanting to hurt their baby, or might be worried about that their OBs, their doctors might be worried about putting them on it. And then we knew women were hesitant, even though for many years the flu vaccine had been recommended during pregnancy. We knew that some women weren't getting it. So after we did that paper, we several people at CDC said, what are you going to do next? And I said, well, I think we need to get some expertise from the outside. Let's have a meeting. And so we had this meeting. We brought in about 50 people from across the United States and some people from Canada to discuss what should we do if there's a future pandemic. You'll see here, this was April 2008. 1 year later is when the H1N1 pandemic started. So the good news is we had prepared, we had information ready, we had information ready to go on the internet, ready to send out to OBGYNs and to let women know what to do during a pandemic. So I had written this paper. It had not gotten published yet, but I got the galley proofs. You get galley proofs of a paper before it goes into the journal, into the hard copy of the journal, and I'd gotten galley proofs the same week as the first 2 kids in California were identified with the H1N1 flu, the swine flu from a few years ago, from 2009. So we very quickly got information up. We were able to share information. And this was my first opportunity really to work in CDC's Emergency Operations Center. And this is the big room every day where we had meetings. This was just for the leaders of different groups. And then here you can see the rows and rows of computers and people sitting next to each other. Not very good infection control, you can imagine, in this sort of situation. But there were also rooms on every floor. There was a 12-floor building. There were conference rooms on every floor that were filled with people working on H1N1 flu. And I started working on this. It was actually really invigorating, and I really kind of caught the bug of wanting to work on emergencies. And the remaining part of my career at CDC, I did focus on emergencies, or much of it. Here you can see this is the org chart. This is in an emergency response. It's very different. So these people, normally, most of them didn't usually work on influenza. You know, some of them worked on violence prevention, some of them worked on heart disease, some of them were like me that worked on birth defects. We all were working on influenza. We all reported up this chain to this incident manager or incident commander, who was Steve Red, and he reported directly to the head of CDC, which actually when it initially started was Rich Besser, who later was on one of the evening news shows as a medical expert. And then later it became Tom Frieden. So I was someplace way down here and started working on H1N1 flu. So our job, we had said what we thought was going to happen in a future pandemic, but we didn't know what was going to happen. And we started collecting data to try to figure out what that was. We published these 2 papers really shortly after the pandemic started. This pandemic started in April of 2009. Normally it takes about a year to get a paper published. You can see that this is published just a few weeks later. On May 12th, we reported 3 pregnant women, one that had died in Texas, and the only reason she died is that she happened to be pregnant during a pandemic. She didn't have a lot of underlying illness. It just hit her lungs hard and she got severely ill. Then we published this paper here on H1N1 influenza during pregnancy in the USA. In this, we had 34 cases. We saw infections and deaths in all 3 trimesters. We saw that pregnant women were more likely to be hospitalized, about 4 times more likely to be hospitalized and more likely to die. And we looked at most of the women who died had been previously healthy. They were just unlucky enough to get pregnant at a time when a pandemic was starting. And we noticed also, we had been recommending from the very start that women should go on Tamiflu, but we were realizing that the initiation of starting on that Tamiflu was often delayed. And what we found out later that was risking their lives, because starting Tamiflu earlier was able to reduce the risk of intensive care unit admission and death. And I'll show you those in a minute. So this is the second paper that we published in JAMA, the Journal of the American Medical Association, in April of 2010, so about a year after the pandemic started. We had data on all women in the United States who had pandemic influenza. And what we found is that about 5% of deaths in the United States from H1N1 influenza were among pregnant women, but pregnant women only accounted for about 1% of the general population. So if you were pregnant, you were about 5 times more likely to die. The other thing we noticed, and this is when I really felt like, oh my gosh, what we did really made a difference, is we found that early treatment was associated with fewer intensive care unit admissions and fewer deaths. So this is looking there, this is one line of a great big table that's in the JAMA paper. But you can see that if you got treated late, more than 4 days after your symptom onset, versus if you started early in the first 48 hours, which is what's recommended for Tamiflu, if you were treated late, you were 6 times more likely to be admitted to an intensive care unit, and you were more than 50 times more likely to die. So this is where we really realized that we had saved lives with the work that we had done. So after that, I was asked to apply for a job and got it to be the deputy director of the influenza coordination unit. That was the group that was in charge of pandemic planning at CDC, and I got to do a lot of I was only there for about 3 years, but I got to do a lot of very interesting things during that time. I worked on an outbreak of H3N2 variant flu, a swine flu that was in the Midwest, this H7N9 flu that was in China. I was the deputy incident commander for that response. So I went from the bottom of that org chart to the second to the top, and then the MERS-CoV, the Middle East Respiratory Syndrome, the previous coronavirus to this COVID. So that was in 2014. It's something that's transmitted from camels to people, and then eventually it's able to be like COVID, it's able to be transmitted person to person, although not as easily as COVID. And the people tend to get much more sick, which is bad if you get it, but it means you're not out and about and transmitting like a lot of people with COVID are. So during that time, I worked very closely with the head of CDC during that MERS response, because I was, again, the deputy incident commander. And Dr. Frieden, the head of CDC, asked me to apply for this position as acting director. The person who was in charge of this group was leaving to be a dean of a public health school in Nebraska, and he said, I'd like you to apply for this position. So I applied. To be honest, I thought my chance of getting it were about 0, but he called me a few days later and I got the job. This was actually, for someone that hadn't had a lot of leadership positions at CDC, was a big job. There were more than 900 people in this group that I was supervising, and it had a $1.3 billion a year budget. So lots of money and lots of people that I was responsible for. But at the time, this was where the Emergency Operations Center for CDC was. And I thought, well, this is an okay time, because there weren't any emergencies in there at that time. Well, a lot of stuff happened pretty quickly. So in this big group, in this 900 people, there was the emergency operations group. That's where, as I told you before, that's where those responses like to H1N1 flu, to COVID, to Zika, to Ebola go. I was also in charge of the division of select agents and toxins. So whenever there is something, this is the group that makes sure that labs treat things that are dangerous to all of us safely. So I had this job just for a few days, and I had gotten on an airplane and I was on my way to give a talk in Seattle, And you know how on your airplane you can log in and you can look at your emails, and I logged in and I got an email from one of my employees, one of the division directors, saying, call me as soon as possible. And I wrote and I said, I'm on a plane, I can't call you. Can you tell me what it is? And he said, I can't tell you by email. So what I found out when I landed was that somebody at the NIH had found some files labeled as variola, and of course variola is smallpox. And there's only supposed to be 2 places in the whole world that smallpox is supposed to be at CDC in a very, very secure location, and then in USSR and Russia. But it's not supposed to be anyplace else. And these were samples that had not been cleaned out of a cold room for many, many years. And over the next few days, I spent, really, it was over the 4th of July weekend, working with the people that my new employees, my new staff, and with people at NIH and a lot of police and a lot of people helped to get these samples back safely to CDC. At the time, I have to admit, we weren't really sure it was smallpox, but we felt like we had to assume it was. It turned out that it was smallpox. Then we thought, well, it probably wouldn't have grown. It probably wouldn't have made anybody sick. But again, we had to assume that it would. And when CDC did the testing on it, it was found to be alive. So it really could have been a very serious situation. But fortunately, it was brought safely back to CDC without any problems. But that was sort of my first test in that position. Then on the 4th of July, you know, I'm a runner. Irene's told you I'm a big spin class person. I had gone to do the Peachtree on the 4th of July, and I brought my personal cell phone, but my CDC cell phone was a BlackBerry. It was really heavy, and I'm fairly competitive, and I didn't bring my CDC phone along because all my staff had my personal cell phone. So anyway, I got home, and I hadn't given Dr. Frieden my cell phone number. And when I got home, there was a note from him saying, are you available and what are your best numbers? Of course, I thought it was going to be about this whole situation with the smallpox, but it wasn't. So I responded, just, you can see I was about 20 minutes before I responded to him, and I said, I can talk now, what's up? He said, I need to talk to you about Ebola. And to be honest, that was the first time I'd ever really heard anything about Ebola. And what he told me that day was there was an alarming rise in cases of Ebola in West Africa, and wanted to know what my thoughts were. And remember, I've been on the job less than a week. What are my thoughts about whether we should activate the Emergency Operations Center? Of course, I'd been involved in lots of responses, so it wasn't quite as much like she doesn't know anything at all. She just started the job. But I certainly hadn't been responsible for something big like that before. So you can see here, this was my spot in the room. We had lots and lots of meetings in this room over the Ebola response. And you can see what I was actually not in this case, very different from my other roles in responses. I wasn't really responsible for the science of the response. I was responsible for the Emergency Operations Center, making sure that trains ran on time, that there were places for people to meet. If they got to a room, I was the boss that made sure that they had a computer sitting there to work. I made sure that all these people, this is actually not cases of Ebola, they went up a lot faster. This was actually people from CDC going to Guinea, Liberia, and Sierra Leone. And so it was getting people in the field, getting them in a safe way, because they had to have personal protective equipment, so that we wanted to be sure that they didn't get sick from Ebola. So just as a reminder, Ebola was this was the largest Ebola epidemic in history. There's been one since, but it's been big, but nothing like this one. And this was CDC's largest international outbreak response in history. At first, when I would sit every day in those meetings, starting on July 9th, when we activated the Emergency Operations Center, I would think, when is the rest of the world going to hear about this? When are people in the United States going to hear what's happening and how severe this outbreak is? And, you know, I really was worried, why are people not hearing about it? And then when they did, I was wishing that they hadn't, because we were on the front page of the newspaper every day. There was a healthcare worker, a doctor in Liberia that got sick. He came to Emory because Emory had had a lot of experience in treating severe illnesses like this. And he came in, and the American people kind of lost their minds, even though the risk of spread to somebody in the United States was very, very low. There was a lot of pretty negative press about us at CDC. In the meantime, we needed to be focusing on dealing with all this negative press in the United States, and the numbers were continuing to just go up and up and up. And really, the outbreak was spiraling out of control. We really were beginning to worry, is this something that we can ever deal with? And President Obama came to CDC to talk with all of us and to talk about Ebola. And it was actually, that to me was sort of the turnaround time. It was September 16th, and I thought things are going to be better. Here you can see the room. This is the back of my head here. This is the back of my head here. This is in the meeting where we briefed him on the Ebola situation. And this is his press conference afterwards, where he committed to having it be an all-of-government response. So not just CDC and NIH and FDA, but also including the Department of Defense. And the Department of Defense, obviously people at CDC can't build emergency operations center. They can't build Ebola hospitals, and that was what was needed. So it was really a turnaround point, I think, for the outbreak. And we did start seeing numbers start going down in Africa, in West Africa. But then there was more in the United States. And I guess you guys probably are all too young to remember this, but there was a traveler that came from Liberia to Texas, to Dallas, Texas. The hospital didn't have a lot of the infection control in place. And so 2 healthcare workers, 2 nurses got sick. And then later on, there was a person in New York City that was confirmed to have Ebola. So there was a lot of focus on the United States, when really the biggest risk was in those countries in West Africa. So at the end of that time, I did that job. I was actually initially asked to do it for 3 months. It was extended to 6 months because it wasn't really a time to hire somebody new. They were looking for who the permanent person was going to be. And so at that time, I had wanted to go work on the Morbidity and Mortality Weekly Report. This is the #1 epidemiology journal based on citations. And so I went to that position to be editor-in-chief. And I had been in this position just a few months, about 10 months, and I had continued to be interested in birth defects and genetic disease, because that's really my training. And one day, because I was the incoming president of the Teratology Society, which is the study of birth defects, we got this email. We are concerned about the introduction of new arbovirus in the continent, in particular chikungunya and Zika viruses, and would like to provide tools to the country to study and identify potential congenital arbovirus, mosquito-borne infections, including their possible teratogenicity. And I was like, I've thought about West Nile before, and this is a possibility. This is a possibility that mosquito-borne infections could cause birth defects. And so initially, I was busy with my brand new job, being editor-in-chief of MNWR, but I knew that I had a lot to offer on this team. I was an expert in birth defects, and I was an expert in emergency response and infections and pregnancy. And here you can see in January of that year, I was asked to come over and work in the Emergency Operations Center. It said initially I would see this work for perhaps 2 weeks or so. I worked on Zika for several, probably a couple years after that. So it took a lot longer than we initially thought. So one of the things that I was asked to do is to try to determine whether Zika virus causes birth defects. And now it all seems so obvious. Well, of course it does. But at the time, there was a lot of question about it. First of all, a lot of people that got Zika are like COVID, that they didn't have any symptoms. So if a baby was born with severe microcephaly, the small head that you see with kids with Zika, and you ask the mom, she said, "Oh, I wasn't sick at all during my pregnancy." And then you say, "Well, it must not be Zika." But not really, because they are without symptoms. The lab testing wasn't really available, and it's not very good, still not really great. case definitions of what's microcephaly. How small does your head have to be? Varied. Mosquito-borne viruses, we were worried about West Nile, but we'd never been able to prove it was a cause of birth defects. And then there were lots of rumors. And this is, you know, certainly we've heard this with COVID, a lot of the rumors that circulate on social media and so on, that really, I think, caused problems with emergency responses. Certainly we've seen this with COVID. People were saying, well, maybe it's the insecticides that you use. It's not the mosquito itself or the virus. Maybe it's vaccines. You know, the people that are vaccine people were saying they thought it was because of vaccines. So we started seeing these pictures of these kids and seeing that this wasn't just a small head, that it was sort of almost a collapsed on itself head. This is a child from Brazil. And you could see these rugae, these overfolding of the skin at the top of the head. And here you can see this is a 3D CT scan where you can see that the skull kind of collapsed on itself. And here there's overriding of the sutures. Normally your skull, when you're born, has, you know, when you touch a baby's head, you feel that soft spot on the top of the head. That's so that the kid's head can grow really fast in the first year of life because there's so much brain growth. But these kids didn't really have a soft spot at all because they had overriding of those sutures. And I started saying, this looks familiar to me. I think I've seen kids with this before. And I had seen a case when I was a genetic counselor before I went to medical school with something called fetal brain disruption sequence. And this is a pattern of defects. We had published it. It's a pattern of defects where there's damage to the brain. The damage could be a virus, or it could be a stroke, or it could be something else. In this child, we thought it was maybe a stroke. And then the child has collapse of the skull, and they have these rugae, these overfolding on the top of the child's head. So we discussed that this was, so most previous birth defects causes, like rubella, like Accutane, the acne medicine, had been confirmed because they caused a very specific type of birth defect. Thalidomide, you know how thalidomide has children with very short limbs. And so we made the case in the New England Journal, and they decided to publish it, that this was a very specific type of microcephaly. It wasn't anything just general microcephaly, and that Zika was the cause of it. And here are some of the newspaper headlines that came out. Zika virus definitely causes birth defects, CDC says. Zika definitely causes birth defects, US officials announce. I was like, oh my God, I'm a US official, because I did the press conference for this. So this is what we postulated happened. We said there was destruction of existing brain tissue and disruption of future developmental processes. That's by the virus that the woman got because of the mosquito bite. It resulted in the brain being smaller than usual, and that meant the skull was smaller, and that meant that there was overlapping of those sutures. Those skull bones overlapped rather than having a soft spot. The soft spot was completely closed. And then the redundancy of the scalp. The scalp was really meant for a bigger head and brain. And then the kids had severe neurologic problems. They oftentimes couldn't hear, couldn't see, couldn't swallow, very severe issues. And we proposed that was caused, this is in a later paper, we proposed that this was the congenital Zika syndrome. So since then, we've published lots of papers on Zika virus disease. This is only a handful of them. I think I've published about 20 talks on Zika, 20 papers on Zika virus. I looked on my CV, I think I've given 52 talks on Zika. I was asked to give talks all around the United States during that time to make sure that clinicians, pediatricians, and OBGYNs knew what to do with babies that were born with Zika. So there's still a lot of questions. How wide of potential health problems can you have from Zika virus? What's the level of risk? We think about 5 to 10% of women who have Zika virus during pregnancy have a baby with a problem, but it could be higher because we haven't followed those kids very long. When during pregnancy does Zika virus pose the highest risk? We think it's probably first and early second trimester, but we we think it even can occur later in pregnancy. And then what are the other factors that affect the risk? If at first there was a lot of concern that if you'd had a previous infection with dengue, maybe you were at decreased risk or increased risk, maybe if your nutrition wasn't good. So we don't really understand all those questions. So I just wanted to finish with a little bit of a discussion with COVID. I came here to the University of Florida in July of 2018. I was hired to be a geneticist, and I was hired to work on setting up, making sure that people were getting the genetics care that they need at the University of Florida. And I see kids in clinic. I'm back to seeing kids in clinic again, which I really love. And then, as you all know, about a year ago, we started hearing about this virus in China. And I have to say, from my years of working in pandemic planning, it sounded very early to me like it was going to be a pandemic. And so I started talking to my colleague, Denise Jameson, who, as I told you, she's now chair of OB at Emory. And she and I decided to write our first paper. It looks like I didn't even include it on here, but our first paper was COVID and pregnancy, what obstetricians need to know. So very similar to this one, but now this one's about vaccines that we just published last week. But we published that first paper, and then now I think I have about 20 papers about pregnant women. You can see about pregnant women, about children with COVID. What does COVID mean for families? We just published this one here. 1 year later, what do we know about how COVID affects kids? We just published this one about COVID vaccines and pregnancy. Should women get a vaccine if she's pregnant or not? And then we published, I published, I guess, 3 or 4 other papers more generally. One about concern about the that CDC wasn't being able to allowed to do their job. I've published a couple of those, and one in New England Journal and one in JAMA. So I'm happy to answer any questions. I hope this has been of some interest, and I'm hoping if you have questions, you'll turn on your cameras so I can see you. Is anybody there?
Thank you so much for all your talking. It was super interesting. I really like your work about Zika because I actually had like a family friend who was pregnant and she had Zika virus after she went traveling. So it's really good to hear about all the work you've done and like knowing that like it like affected someone that I know. So that was really interesting to learn about. So thank you for that. One of the questions I had was like in the field of medicine, I know like you had your personal experience with your brother, but why did you consider like pediatrics and epidemiology over any other field?
Yeah, as you can hear, I didn't really know what I wanted to do. And I grew up, I'm sure it seems like the dark ages. I mean, I grew up where I didn't know any women that were doctors in my small town. I grew up in a very small town in Minnesota. And I have to tell you, I didn't even know it was possible for a woman to be a doctor. I remember one time talking to my mom about it. My mom was a nurse, and she was like, you can't be a doctor, then you can't have children. And my mom actually she's never really been that thrilled about me being a doctor, except when she wants free medical advice. But other than that, she really didn't want me to. She thought I was going to ruin my life. I was going to work all the time. Some of that probably pretty true, but I went to undergrad. I kind of tripped around not knowing what I wanted to major in. I initially was an undecided major for the first 4 years. I got very involved with the choir, wanted to go to Europe with the choir. And because I wanted to go to Europe with the choir, I decided to spend an extra year instead of graduating at 4 years and got a math major. And then I thought, well, what can I do with biology and math? I had biology and math majors and a minor in chemistry, and I thought, well, genetics is good. And I heard about this new career as a genetic counselor and decided I could help families like mine who had a child with Down syndrome. And initially was a genetic counselor, went to genetic counseling school. That takes a master's degree. I went to the University of Wisconsin for that, got a master's degree, and then came down to Florida. There were only 2 jobs available in the whole country. I didn't really want to be that far away from my family, but I came down here and took a job here. And my new boss said, "Why didn't you go to medical school?" And I said, "I think I should have. I didn't know I could. I didn't know it was something that women could do." And he said, "Well, we're going to work on that." So anyway, it was a great. I worked as a counselor for 3 years, and then went to medical school, and always knew I wanted to be a clinical geneticist at the end. But you can hear that then I didn't really become a clinical geneticist. I mean, my first work at CDC was clinical genetics, but then I really got off topic and got to do a lot of cool things related to infections and emergency response. And I think, a few years ago, I was asked to give the commencement address here at UF. And what I've told people is, you think that, well, how did I get off this path of I was going to be a clinical geneticist at a university, and how did I end up at CDC? And then it ends up being so much cooler than I thought. So I think, I encourage people to follow their path, follow their dreams, but don't be so set on it. Sometimes something can be a lot cooler than you think. You can trip onto something a lot cooler than, and to be honest, I sort of tripped on, I was sort of at the right place at the right time, and always I worked really, really hard. So it wasn't, people keep telling me I shouldn't play down that it was a lot of hard work, but it was very cool. So
do you recommend the vaccine for pregnant women?
I think, like anything during pregnancy, even Tylenol, it's weighing the risks and the benefits. So if you're somebody who works from home and you don't have any older kids that are going to school and you're not going to be exposed, probably the safest thing would be to wait until the pregnancy's over. But COVID is worse in pregnant women than it is in the general population. Pregnant women are about 1.7 times more likely to die if they get COVID, and their babies can have effects too. So if you're someone, for example, you're a nurse or a physician in a hospital, or you're a teacher in a school and you're pregnant, I don't think we have any reason. Now, it hasn't been tested in pregnant women at all. It's been tested in pregnant animals, but it hasn't been tested in pregnant women yet. But if I would get it if I were pregnant, and I think the likelihood of that little piece of mRNA causing any problems with your pregnancy is very small. But everything is risk and a benefit. Everything you do in life, if you're going to avoid all risk, you wouldn't get out of bed in the morning.
So if you had a magic ball, when is COVID over?
I think at the end of the year, but it all depends on what we do now. It depends, there's this new strain out there. If we all are out there and getting exposed and not wearing our masks, and it's just going to keep going up and up and up, and we can't get the vaccine into enough people quickly enough. They can't make it fast enough. They can't get it in enough arms. Then we're going to be at this a long time. So I'm hoping that people will realize what a dire situation it is right now. It's really bad. There's a really high number of people dying every day. I think when you have the chance to get the vaccine, for kids, it's going to be a while. It's been tested down to, the Pfizer's been tested down to 16 years old, but there's more testing that's being done now. I'm getting my second dose of the Pfizer vaccine at 5 o'clock. So I feel like the vaccine, there's a lot of data that shows it's safe, and it's much more effective than we ever imagined was going to be the case. So it's very exciting.
So is the vaccine going to be something that we're going to have to take every year, or do they know?
We don't know right now. The first person that got it in the clinical trial was July 27th. So that's the very first person that got it. The way that these viruses are starting to change, I think it's going to be like flu. I think my guess is that it's going to be something we'll need every year, every other year, like the flu vaccine. but I don't think we have the answer to that right now. So.
So are there any other questions? You guys, it's your opportunity to ask questions. Many of you are interested in a medical career. Just unmute your video or just unmute your microphone. This is a very quiet class. Okay. Aditi, do you have any? Okay, there goes Ashim.
Yeah, so I was just wondering, you know, the UK is doing this thing where I think they're giving all their doses, like the first dose first, like trying to get everybody maximum vaccinations like in the beginning, and then, you know, they're waiting a long time to get the second dose to everybody. So do you think that that would be like as effective at like that's an effective vaccination plan, or do you think that like the effectiveness goes down if they wait longer than that?
I think we don't know right now. We know that the testing was done with people getting 2 doses and 21 days apart for Pfizer and 28 days for the Moderna vaccine. I think right now, I think what the UK is doing is because they feel like they're absolutely in a dire situation. They are it's sort of one of those last ditch kind of efforts. I hope we don't get there, but we're rapidly heading towards that in the United States. I hope we don't have to go there. I hope we can give the vaccine as it's recommended. I'm thrilled to be able to get I've been sort of nervous that, you know, I'm thrilled that as a healthcare provider, I'm able to get my second dose today, because I'm worried that, you know, you're just not going to have the same protection. You're not going to know the length at all of protection if we start using it differently than what the clinical trials, the studies that were done used it. So that's a great question though. And I think the UK is, you know, I think people in the United States right now, the experts like Tony Fauci feels that we need to follow the science. And I'm a scientist, I feel like we need to follow the science too. But if we get in a really, really, really bad situation where, you know, this new virus is not going to be as forgiving, the new variant is not as forgiving. I think where before maybe if you took your mask off for a few minutes, it wasn't that big of a deal. This is spreading at 1.5 to 1.7, 1.8 times faster, so easier. So I think we really, really can't let our guard down right now. So, and we're all sick of it, right? We're all sick of it. We're all sick of wearing masks. We want to go back to the gym. We want to go back to spin class. We want to, you know.
I don't know if I do. I'm enjoying Peloton, to be honest.
I know, I'm loving my Peloton too. So I'm trying to decide about whether I should get the tread. So
yeah, I mean, I love it. But who's your favorite instructor? Not that that's completely off.
I think Cody, but
Cody, yeah, Cody's my favorite. But I like Dennis, and yeah. So guys, do you have any other questions? I know you guys must have some questions other than about Peloton.
Cody is the best. Thank you, Olivia.
He is the best. I mean, my husband hates him, but I think he's hysterical. I just think he's so funny.
Although I did like the Hamilton one. Did you like Hamilton?
Yeah, I liked that one too. Yeah, and I liked Christine's Imagine Dragons. I really liked that.
Yeah, that was good.
She puts music together more like I put music together.
Yeah.
So
yeah.
She was a little more like me as far as teaching. So, and I like to stay in the saddle practically the whole hour. So, favorite discovery or something that shocked you in your career?
I think so. I had was supposed to give a talk. I've been doing some consulting for some companies that want to try to keep their employees safe in COVID-19, and I was asked to give a talk to the board of directors, you know, which are very rich people, and I was so nervous about it. And I was supposed to do it on Monday morning. I woke up and there was on my phone saying 95% the original data, the Pfizer vaccine looks like 95% of people are protected. No one expected that. The FDA expected it was going to be a 50%. That was their bar that they had set, is it had to be at least 50% or they weren't going to allow it to be used. Tony Fauci was saying if it's 60 to 70%, we'll be thrilled, because that's more like what the flu vaccine is. So this is really, you know, incredible science, and people, you know, and developed so quickly, but not because they skipped steps. It's really important to note. It's not that they skipped steps. They did every step, they just overlapped them. So normally you would wait and to make sure it's works before you make it, because you wouldn't want to waste the money, but our tax dollars were put towards investing so that they could make it, and then they would have to throw it away if it wasn't working. So this is really exciting. It's something that they had been working on, this technology, while we were planning for pandemic flu, and it's great that this technology has ended up being so for me, that is really cool. So so I'm on the med school admissions committee. If you guys want to talk about med school, I'm on the admissions committee for University of Florida. How did I feel after getting the first dose? I really didn't feel anything at all. I mean, I was very excited about getting it, and I kept thinking, am I going to feel something? Of course, you know, when you first get it, you're not going to feel anything, because you guys have probably read in the news, it's a piece of RNA. An RNA is sort of a message, and then your body makes the antigen, your body makes the protein based on that RNA. And Tom Frieden called this like Snapchat. Then the mRNA is gone. You know, it's like a Snapchat, it's gone. And the antigen is there and your body reacts to the antigen. So I knew right away I wouldn't feel anything. I didn't, you know, the people that have had initial responses are people that have severe allergies to something that's in the vaccine, not the vaccine itself. So I didn't feel really anything. I felt a little chills the first night. The second dose is supposed to be more severe because it's like a booster. I've already made some immune response to it, so it's going to bump my immune response. So I expect tonight, I'm in clinic tomorrow, so I hope I don't feel too awful, but I expect tonight to feel kind of crummy. So I saw some more questions. Let me see. Any tips for convincing stubborn family members? That is so hard. I spent a long time with my parents because my mom kept going getting her hair done and kept going and meeting with friends that would refuse to wear masks. And I've tried to just be persistent to say, I love you very much and I really don't want you to die and you're at high risk of dying. And, you know, I think it's finally gotten to them. They're getting their vaccine on Friday. So, but it's really hard because people, I think this has been turned somewhat into a political issue in our country, and it's not, it's science, but it has been turned into politics. And my parents, it's not the political thing, it's just I think my parents didn't really get the messages or something, I don't know, until I started really bugging them about it.
So any other questions about applying for medical school? Some of y'all will be doing that.
So I had a quick question just about like kind of exploring your interests. I know that we're in high school right now, but I'm considering a like career in public health or medicine maybe. And I was just wondering like what you would recommend to like get a feel of the field, I guess, because I was planning on doing some shadowing and things like that, but because of COVID, like it's really hard to kind of like get out there. So I was just wondering if you had any recommendations.
Yeah, I think if you can do some shadowing, that's really helpful. I know it's harder right now. Keep in mind that shadowing doesn't have to be in person. If somebody's doing telemedicine, maybe they'll let you watch telemedicine. Like I'm doing a lot of telemedicine now, and tomorrow there's a student with me all day. So sometimes, you know, they have to go through a bunch of hoops here at University of Florida. If they're a student here, they have to fill out some forms to make sure they aren't going to, you know, say something to somebody else. They have to do some training, but there may be somebody that would be willing to let you do telemedicine. The other thing, there's a lot of books about medicine that I think are, like before I went to medical school, I read, there's a book, A Not Entirely Benign Experience, and it's by Perry Class. She's one of my favorite writers. It's Klass. She writes for the New York Times. She's a pediatrician in Boston. When I was a medical student here, I invited her to come down and give a talk at UF, and so And a few years ago when I did the Zika stuff, she called me because she was writing an article for New York Times about Zika, and I got to be back in touch. But she's recently written something about public health, which is very cool too. So reading some books by her, there's some books in medicine that are fairly negative, that give and I don't think it's bad to read some of those either, because I think, really reading about the goods and bads of medicine is helpful. So I think right now you can focus on some of that reading, and then later I really think, so what we look for when we're interviewing med students, we try to make sure they know what they're getting themselves into, that it's hard work, it's a lot of years of school, that it's pretty, you do start once you graduate. My daughter just graduated this last year and she's now a resident, but she's not earning great money. I mean, I think 60,000 a year or something, but she's working really long hours, and that's 4 more years afterwards. She's doing a psychiatry residency. So we really want to make sure that you're not going to get in the first year and say, I have to study all the time, I quit, because, that spot is something that we see as a very precious thing. You can only train so many medical students a year. And so we like it when people have done shadowing. We like it when they've done some research, whether it's epidemiologic research or whether it's some lab research, but we like it when people have done some research. We like you to have some interests outside medicine. The young woman, I interviewed a woman last week that was very impressive, but she'd done a lot of dance and piano, and we like people who have focused something in their life that really got into something, whether it's sports or whether it's so.
Yeah, because like my parents are kind of like your parents are kind of trying to push me away from medicine, because they're like, it's really long hours, you're gonna have to train until you're like 30 years old, so it's better if you just like go into something a little bit easier. So I'm trying to figure out if that's something which I actually want to do, because right now I really like it. So yeah.
Yeah, I have to say that I'm so glad that I did it, because I was a genetic counselor for 3 years before, and so I had a job and I was earning good money. But I am so glad, the good thing about medicine is that I've been able to do whatever I wanted. I was able to do a lot of public health stuff. I was able to do, now I can go back and see patients in clinic again, which I really love. I love making a difference with patients on a one-on-one basis too. The families are so grateful when we help them figure out what caused their baby's birth defect so, there's a lot that's really cool about medicine, but my parents are really against it. But you have to do what you want to do, right?
Yes.
Olivia, did you have a question?
Yeah, I did. I kind of wanted to ask, like, what do you think about like the post-pandemic, just kind of the demand for like healthcare careers, and whether it's going to be like an increase in burnout for healthcare workers, or do you think there's going to be like a higher demand, and so they're going to have to like recruit more young people to go to medical school to like bring in the new force of like healthcare workers? Or I just want to see what you thought about that.
Yeah, I think so far we've had more people apply to medical school at UF this year than ever before, and people are calling it, people nationally are calling it the Fauci effect. That people realize that, doctors can be kind of heroes, and so I think there will be more people interested in it. I think there are a lot of people that are getting very burnt out, and it's been a really rough year. I think most physicians, a lot of people are, have loans that they have to pay back, and they can't quit, right? If you have hundreds of thousands of dollars of loans. But I think people who have other options may decide this is the time to get out, especially the people that have been on the front lines. I've been seeing patients in clinic and I'm doing a lot of telemedicine, but people who have really been on the front lines. And, I do think it's been really hard, especially when you go to work every day and you're trying to save people's lives, and then you stop at the grocery store on the way home and you see people refusing to wear masks, and all the things that we're saying, don't get this because you could die, and we don't have enough beds in our hospital right now, and if you get in a car accident, we can't take care of you. and then they see people flouting the recommendations. I think people have gotten very discouraged. So I'm hoping there's a lot of the efforts in you know, physician organizations right now are how to support physicians and not have them get so burnt out. So I think there will be more openings than there would normally be, but there's also seems to be right now a lot of young people are wanting to do it. I think because you know, there's been a little bit of the hero thing, you know, of the people that are really on the front line. So, and there's, I mean, it's not for everybody, but if it is for you, it's the coolest thing you can do, I think. Other than being an exercise teacher, right? I mean, you know, where you make a difference in people's lives every day. I thought like massage therapists, they make a difference. You know, there's so many different ways you can make a difference, but medicine is one of them. So teachers.
I really miss teaching, but I don't miss the teaching as much as I miss the members.
Yeah.
And none of them have gone back. So
yeah,
I think there's one person that I know that went back, and all the rest of them are working out at home, which I think is going to probably be the new reality.
Yeah, I think so too. Especially where you can have some camaraderie on you know, and the things like Peloton.
Yeah. And
if I didn't have that, if I just had to sit on the bike by myself, forget it, you know. But
we have 2 bikes. So my husband and I usually ride together. And so I get all of his criticism of the music that he used to give to me when I was making the classes. And I'm like, oh my God, he just doesn't like anyone's class. But so it's fun because we look at each other's heart rate monitors. It's just stupid, but it's fun.
it is fun. So.
Yeah. So
anything else?
Elizabeth.
Oh, yeah. You're up. Thank you so much for taking the time out of your day to come talk to us. It was so interesting hearing about like your journey and like the different things you've experienced. So thank you so much for that, as well as answer. And it was really fun and interesting and gave a good insight to this field. So thank you again.
Great. Thanks, you guys. Good luck to all of you.
Thank you so much, Sonja. Good luck on your shot today.
Yeah, thanks. Let's hope it's.
I recommend a glass of wine afterwards. Just saying.
Yeah, well, definitely. All right. Thanks, you guys. Yeah. Bye-bye.
Okay. Bye-bye. Thank you. Okay, guys. We are done for today. So if any of you would like contact information for any of the people that spoke today, you can always drop me an email. If you want to go on LinkedIn and connect with any of them, I think the only one that might not be on LinkedIn is Joan Compton. I would suggest that. I would, if you have other questions that you were just too embarrassed to ask, you can always email them. She is very approachable, Dr. Rasmussen is. And Tim Cunningham, you guys can look on YouTube. He has all kinds of YouTube videos. He's really cool. So feel free to reach out to them and reach out to me if you have any questions. So our next program day is in March, and I don't know what we're gonna do. I'm hoping we can do City Day, but I guess it just depends. If it gets better, if it doesn't get better, we'll figure something out. Okay. So does anybody have any questions for me before we stop? So could I ask you guys if you guys would just take and unmute yourself, unmute your videos so that I can take a photograph of for, you know.
Also, guys, if you have an idea for March outside of City Day, if we can't go, send them to Ms. Sanders just as an idea of what you like hearing about or what we could end up doing. Send her some ideas.
I mean, because we have a few other speakers that I'd really like to have speak. And so, you know, it might be something very much like it was today where we have different speakers. I am in the process of setting up the 3 shadowing days. So I'll be sending that information out shortly. But I I already have the business and technology one set up. I'm waiting on the medical one. But I feel like the medical people got quite a bit today. So you guys might even be able to count that as your shadowing and just write something about that or do a video. That's what I'm going to ask you guys to do, is a short video about what you learned by these shadowing opportunities. So if you guys want to count the one today as the medical, that's fine, because it was heavily medical. So Tamara, can you turn on your video? Because you're the only one that doesn't have it on in this picture. There we go. Okay. So everybody can smile. One. Oh, I'm going to be shown like this. Can one of you guys take a screenshot and send it to me? I always count on other people to do my work. Can one of you do that? One of you volunteer to do that for me. Who's going to do
that?
Okay. So tell everybody when to smile.
3, 2, 1.
Okay, then you have to text that to me. And then the only last thing I have is go Saints. They're playing the Bucks this weekend. So otherwise, you guys have a great evening, okay? Bye.
Bye, Sandra.
Have a good day.
No, not go, Brady. Who said that? Wrong. Bye, guys.